Now you've done it. You've made it to the end. So this last chapter is the end of life. We started with the fertilization and ancestry at the very beginning, and now we're at the end. So we'll be covering, but we're not going to cover the whole chapter. Mainly what I want to focus on is the bioethics and some legal definitions that are important in the medical side of things. So there's actually a whole literature on how cultural dealings with death and how it varies across cultures and how it's changed over time and things like that. So that's actually a whole specialty class in sociology. Okay, the term clinical death is when a patient, this is the moment that goes on the death certificate. So this is when a patient is determined to be non-viable and they have all vital signs have ceased, including respiration and heartbeat. So at the moment of the heart's last beat, that's the time and date that's put on the death certificate. So several things are required to determine clinical death. One of them is a flat EEG or electroencephalogram indicating that there's no cortical activity in the brain. EEGs don't measure subcortical activity, but only activity in the cerebrum up against the skull. So that's where voluntary motor responses and thinking and visualizing and all that is. No vital signs like blood pressure, respiration, and heartbeat, which includes the pulse oximeter reading, and no sign of diaphragmatic movement when the ventilator is turned off. And then reflexive, no, the absence of reflexes like pupillary reflexes, corneal reflexes, gag reflex, cough, oculocephalic reflex, and oculovestibular reflex. Now, all of these are cranial nerve reflexes. So that means that the nerves up in the brain are not responsive. There are no reflex arcs up in the brain. Now, you can actually have the death of the brain, but since the heart has its own nervous system on the sinoatrial node, the heart can continue to beat, and certain functions from the neck down can continue even when the brain's not functional. So whole brain death is when there's no breathing, so the brainstem is not working, so they require a ventilator. There are no brainstem reflexes, like the ones we talked about before, the cranial nerve reflexes and the reflexes up in the brain. Heartbeat is intact, and there's a flat electroencephalogram, so the outer part of the brain is not showing any electrical activity when you do an EEG through the skull. So this is what patients, when there's no probability of recovery, then they're considered brain dead. Here's an example of an EEG. This shows the electrical activity in the brain. This is actually an old technology. It's been around a long time. But you can see here on a normal EEG up at the top, all the leads are showing electrical activity. And those are brain waves. Down below where you see a flat EEG, that is what it looks like when someone has no cerebral function in their brain. Now you can have the next level up is where you can have some lower brain activity but no upper brain activity, and for a long period of time this is called a persistent vegetative state. So the most common symptoms are a semi-conscious or unconscious state where they don't respond to environmental stimuli, irregular sleep-wake patterns that don't match the light-dark cycle. In other words, they're in and out of sleep. Lack of self-awareness or environmental awareness. They don't wake up. No voluntary responses to stimuli. So like grabbing, reaching, anything like that, directing their eyes in a certain direction as a response to stimuli. Coma, which is when they can't be woken up. Leaking of stool or incontinence, and leaking of urine, which indicates that that's a paradoxical action there. Normally, the anus is at tension when a person doesn't voluntarily release stool, and their urinary sphincter is at tension. So when a person's in a persistent vegetative state, that tension may not be maintained. And then rhythmic muscle contractions. So neuroscience for a person in a persistent vegetative state are withdrawal to pain stimulation, so the reflex arcs are working. If you stick them in the bottom of the foot, for example. Breathing without assistance, that is, they don't require a ventilator, so that tells you that the brain stem is still functioning. Normal heart rate regulation, which means their heart is still connected. The sinoatrial node is still connected to the medulla and the brain stem. No response to noxious stimuli. So that's usually tested. You snap some ammonia, put it under their nose, and see if they show a response to that. They usually won't. And then basic reflexes like the Babinski reflex, pupillary dilation and constriction to light, pen light, and blinking to a loud noise. Now, on the bioethics side of this, one of the real important issues is euthanasia. There are really two kinds of euthanasia. Euthanasia is when someone assists somebody in some way to die a natural death or an induced death, depending on whether it's passive or active euthanasia. So passive euthanasia is what's common in our situation. Hospice is palliative care. That's when you have no curative medical care. It's just to make them comfortable. You withhold life-saving or life-preserving medical treatment. Usually there's a DNR, a do not resuscitate order. We'll talk about medical powers of attorney and living wills in a minute. So this allows a person to die a natural death. Active euthanasia is legal in some states, but not in most. It's a physician-assisted ending of life when there's no prognosis for recovery and the patient has no desire to continue. First of all, the person has to pass a mental status exam, and they can't be determined to be suicidal. The illness, in most states, the illness has to be severe enough that the person has no quality of life or no prognosis for a return to quality of life. And in those situations, determined by a physician, usually with a second signature, the physician can actually administer medication to allow the person to die. Or in some situations, give the person the medication, allow them to self-administer. So the goal is to end suffering. So let's talk about some documents that become important in medical care. When a person does a will, especially if you do it through an attorney, part of that, and of course the will is going to handle all your property and stuff like that, but part of the will is going to be your wishes in the event that you can't make decisions for yourself with regard to your health care. So that's called a living will. That's when a person outlines in detail what they want and what they don't want in the event that they're incapacitated for some reason. In the process of that, there's also a durable power of attorney for health care. And what this does is this is a statement, an affidavit that says that in the event I can't make decisions for myself, I trust this person named in this affidavit to make decisions for me. So that person becomes you in a durable power of attorney for healthcare, but only with regard to your healthcare decisions. No other decisions about property or anything like that